how do you approach a lump or a bump in the side of the neck or in the midline? You can take them both.
So it depends on how the patient comes to you. Most of the time they'll come with a known mass and that they've felt, and very often their astute internal medicine physician has done some sort of imaging study that documents the size and location. So when they come to us, we sort of have an idea of what the mass might be and what further diagnostic evaluation is necessary. And
when you say imaging study, what do you mean? X-ray?
CT scans or ultrasounds of the neck, either one.
So they frequently come with information that will help you in your initial evaluation of that lump or that bump.
Yeah, it focuses our attention on where might this be coming from, and then we pursue the diagnostic pathway to figure it out.
So the thyroid is located where, on the side or right in the midline?
So we're talking about lumps and bumps, but a lot of lumps and bumps are low in the midline of the neck, and that's where the thyroid lives. It's a butterfly-shaped structure that drapes over the trachea, over the windpipe, down low in the neck, just above the collarbone. And the thyroid gland can have bumps. In fact, 5 to 8% of people in the U.S. will have a bump in their thyroid that's of no clinical significance. So it's not uncommon that we see people that have lumps and bumps, and there's nothing to worry about.
Is it easy to feel?
It can be. It depends on the person's, physique.
Neck size.
Yeah, real thick necks are sometimes hard to feel, and long, thin, as we say, aquiline necks are very easy to palpate. But patients will very often come and say, "I've noticed a mass in my thyroid," and we have smart patients in this world that come to us with good education that they've gotten from the internet, and so they have a preconceived notion of what it might be, and it's our job to define it more. The thyroid nodules don't have a side predilection. They don't choose left or right. They tend to be more common in women. We see them mostly in middle age, and for the most part they're benign. So when we see people who have a thyroid nodule, the first thing we want to do as a head and neck surgeon is to get an ultrasound, because it's the tool that helps us define the thyroid nodule the best. It tells us characteristics about that nodule that help us decide, is this something that's benign and really doesn't need any further follow-up, or maybe it just needs another ultrasound in a year, or it has some criteria on the ultrasound that say, this needs a biopsy. If you need a biopsy, we use ultrasound again to guide little skinny fine needles into the thyroid nodule, aspirate some of those cells out. We can put them on a slide and look at them under a microscope, and our pathologists are excellent at being able to tell us, does this look benign or malignant? And in the case that there's kind of a question, it's still a gray zone area, then we're getting better at using genetics and RNA. And
what will that tell you?
That helps us stratify the gray zone areas into low-risk groups where people don't need surgery, or a high-risk group where they're going to need some surgical removal. We've gotten so good with ultrasounds, and we're picking up so many nodules, that over the past few decades, the trend has been towards more thyroid surgery for benign disease. And in retrospect, we've had to sort of examine and ask ourselves, are we doing more surgery than we needed to be doing? And so on the heels of that, the genetic testing has sort of grown, and our knowledge of all that has gotten better, and we'll be able to use specific genetic tests to determine, as this patient, one that we can say, even though it's kind of a gray zone nodule, it doesn't require surgery. Let's table this for a while, look at it again in 6 months or a year with an ultrasound. Or on the other side of the coin, hey, this one sort of stratifies into a more higher risk group, and we need to go ahead and get this thing out. And so we're trying to be smarter. We're trying to operate less, because we know that many thyroid nodules are benign, if not most, and we're trying to do less surgery in those areas. So your doctors that do head and neck surgery are well trained in all these things and use all this data to come to a careful decision for you, the patient.